very slippery, almost like a lubricant. That's basically what it's there for, inside this cavity space. But when we get too much, it becomes a problem. This 0.1 to 0.3 per kilogram is really not very much. It's a small amount. The only purpose of that fluid is to lubricate the two pleural linings there, the visceral and parietal pleura. It lubricates them so that they can rub against each other, but also provides surface tension so they don't pull apart. So basically, this surface tension adheres your lungs to the inside of your chest cavity, if you can think about it that way. So if something were to disrupt this membrane, then your lung would be able to collapse. And that's what causes those collapsed lungs, is when this membrane or the surface tension gets disrupted. Say a bullet goes through the lungs, you now have a hole, air comes in, you lost all your surface tension, lung collapses. So it's very important that there is fluid in here. If you don't have fluid, then there's no lubrication, they can't slide, and you lose your surface tension. But every time you breathe in, your chest wall expands, and then as you breathe out, it contracts, right? So we have a changing surface area that the lungs must adhere to, so it's important that the linings be able to slide against each other. And that's the purpose of this visceral fluid, okay? It is normally drained by the lymph system, so as your body produces it constantly, if suddenly it's not getting drained, you're going to have way too much, and that's one of our causes here. Decreased reabsorption of that fluid into the lymph system. So if it's not getting reabsorbed, fluid levels will slowly rise until you have way too much. You get a big old pocket of water in the bottom of the lung there, or wherever the effusion tends to be. They do tend to sit in the bottom because gravity pulls the extra fluid down, and then you have a big pleural effusion. The other problem that we will see here, other than decreased absorption, is increased production. If your production levels get ramped up, but you're still only pulling away the normal amount, then you're just going to have more and more leftover or residual fluid there until you have a pocket of this serous fluid in the visceral pleura. So basically, what we're looking at is this pocket of fluid. Okay, it's going to cause some symptoms eventually, but they can sneak up on people. And we'll go over that in a minute. We're going to talk about treatment. We're going to talk about how you find them. And we're going to talk about what we're going to do as the nurse when we have a patient with pleural effusion. Alrighty, so let's talk about diagnosis first, because we need to know what actually tells us that our patient has this problem, right? What tells us we have a pleural effusion going on? Well, the main thing we're going to be able to diagnose it with is an X-ray. That is typically where it's going to show up, and we do X-rays a lot in the hospital, so it's typically going to be caught fairly early if it onsets in the hospital. But if your patient is outpatient and then comes in with the problem, they may need to do a chest X-ray just to see what's going on and then be like, oh, there's the effusion. Okay, now we know what we're going to do. Chest X-rays typically are how we find them. They're not the most sensitive diagnostic tool we have. Actually, an ultrasound of the chest is going to be much more precise, and we may do ultrasounds of the chest if we plan on treating the pleural effusion with a thoracentesis, which we'll talk about when we get to treatment. So ultrasounds are the most precise means of determining where and how big this effusion is, but typically we'll find them on chest x-rays. And a lot of patients, if they're on ICUs or step-down units, will get a daily chest x-ray. Especially if they're intubated, they'll always get a daily chest x-ray if they have any kind of breathing tube in that we need to check the placement of. Patients on your gen med floors, probably not getting x-rayed every day nearly at all. They might get an x-ray if they have a change in symptoms, and that's about it. We don't do dailies on those patients. But we have some problems when it comes to the x-rays. Depending on the view of x-ray that they take, and the most common is this AP view, or anterior posterior. That means that I'm looking at the anterior first, and then the x-rays will bounce back through the posterior. So it's kind of like what shows up first. AP is, you're looking at the front view of the patient, so a mirror image basically. That AP view though is going to require a much more advanced amount of fluid, a larger amount of fluid in that space before it will actually show the effusion. You need about 200 milliliters of fluid to already be accumulated before an AP view chest x-ray will show it. So you're going to see your larger effusions pretty easily with that, but smaller effusions might get missed on those AP views. As opposed to your lateral view, lateral meaning from the side, right? So if the x-ray is over here and it shoots the x-rays through me laterally, we're going to only need about 50 mLs of fluid accumulated before it will actually show the effusion. So they're much more easily diagnosed for those smaller effusions on the lateral views. Unfortunately, unless you're going in specifically with the intent of finding that, anytime we're in the hospital checking, say, an ET tube or a tracheostomy tube placement for a vented patient, or someone who's needing daily chest x-rays for progressing their treatment of pneumonia or whatever it is we're doing them for. They're only going to get an AP view. So unless we need to get that lateral view, they're probably not going to get it unless we have reason to suspect that we need to take one. Just something interesting to keep in mind. So what might we see with these effusions? In our larger effusions, the more severe ones, you're going to see maybe some intercostal fullness. Remember that intercostal referring to the intercostal space between the ribs. You may hear some dull percussion sounds, because we all know we do our percussion on our head-to-toe assessment, don't we, where we're tapping around on our patient to hear the noises. Definitely do that every time we check our patient out. So we might hear a dull sound. Remember, lungs are full of air. It should sound kind of like a drum when you're tapping over them. You should hear that hollow resonant sound. But instead, we might be hearing a dull sound like a drum filled with water, because that's literally what we have here, right? An air cavity filled with water. You might have decreased breath sounds on larger effusions. Imagine this growing bigger and bigger, pushing up on the lung. Eventually, it's going to start infringing on that lung space until the lung tissue becomes a little more compressed. And the more compressed that lung tissue is, the more decreased your breath sounds are going to be. So those really big effusions, certainly you will hear decreased breath sounds over that effusion. Hopefully they don't progress to that point, but sometimes they do if they sneak up on you. You never know. Otherwise, they can be asymptomatic. Your patient might be walking around with an effusion and never have any idea if they're small enough, and it may just be they have an acute infection and the body will fight it off and the effusion will eventually get drained again just like normal, or they might need to actually seek treatment. If they are symptomatic, we may see some dyspnea on exertion. Not so much at rest, because at rest your body's not really needing all the extra oxygen, but as soon as you up the oxygen demands on your patient, they're walking, they're going on a treadmill, they're doing a flight of stairs, whatever it may be, they may notice that they're just not getting enough air. This again has to do with that decreased lung capacity from the water sitting on the lungs, right? We're decreasing the amount of oxygen exchange that can actually occur in the functional tissue of the lungs. So they're going to see some dyspnea on exertion, and we may see pain. This is typically a pretty severe pain, and it's going to be on a cough or a really deep breath, anything that really demands a lot from the lung there. You may see some severe pain. Now, this is going to be kind of like from the inflammation going on, but we may see that this has what's like, we're going to call it a false improvement. We may see that as the effusion actually gets larger, the pain, it subsides. It becomes lesser and lesser. And patients will think, I'm getting better. And healthcare professionals might think, they're getting better. They might not be getting better. It might just be getting to the point where the effusion is large enough that it's no longer causing that severe pain from inflammation. I'm not entirely sure exactly why that is, to be honest. But we call it a false improvement. And so it can happen that you assess your patient, they're having this severe pain on cough. Next couple hours you go in, they don't have the pain anymore. That's great, right? Well, we might take another x-ray and the effusion is much, much larger to the point where it's not causing pain anymore. And that is a false improvement. It's not actually them getting better. Okay, so now we need to talk about what we're going to actually do with a patient who has a pleural effusion, right? We need to talk about what the medical team is going to do and what the nurses can do for these patients. So for the nursing side, pretty much going to be the same treatment for a lot of our respiratory patients, COPD or asthma, whatever it is, respiratory problems, typically you're going to see the same nursing interventions. They may need supplemental oxygen. They have decreased lung volume, right? So they're going to have trouble breathing. Decreased oxygen, practice coughing and deep breathing. That is going to help clear some of that out. We want them to continue taking deep breaths, because if they don't, eventually those alveoli will end up collapsing and we'll end up with like some atelectasis from those patients who are too scared to take a deep cough or a deep breath. So we want to make sure that they are actually using their lungs still well. We want to be doing our incentive spirometry as usual, because that will also help prevent the onset of pneumonia and that atelectasis from the alveolar collapse. And we just want to make sure that we're doing good pulmonary health with these patients. If they're vented patients, make sure we're doing good respiratory care. We want to prevent further complications like pneumonia or a worsening effusion. Do what we can. Keep them upright. Don't let them just lay in bed all day. If it's on one side of the lung and not both, maybe just turn them so that side is up. It'll help that effusion kind of drain away, get some of that fluid out of the lungs, right? So just good pulmonary care on the nursing side of things. On the medical side of things, what you can expect the team to do, we're going to drain the effusion, depending on how big it is. If you have a larger effusion that is causing like actual symptoms and we need to get rid of it, if we do an ultrasound and find the fluid pocket and there's a decent amount of fluid in there, they may decide to do what's called a thoracentesis, where they basically take a big old needle, they ultrasound the site, and under ultrasound guidance, they stick the needle into the patient through the intercostal space, wherever the effusion is, and they will drain that fluid away into like a vacuum sealed container. So it'll apply some suction, pull it out, and drain the effusion. And then, again, this is part medical team. They should do this, but nurses need to make sure they do. After that, we need to make sure that they don't pull off too much fluid. 1,500 mLs is our typical amount, and we need to make sure that we do a chest x-ray after that procedure to make sure that we didn't accidentally give them a pneumothorax. The reason being for the limit on how much fluid to actually take out, this 1,500 mLs, taking large amounts of fluid off of a patient at once, whether it's from the thoracentesis, it could be from draining ascites from a liver failure patient, basically same procedure. Anytime that we're like aggressively diuresing a patient, we put in a new chest tube, whatever it could be, pulling too much fluid too rapidly off of a patient will cause massive fluid shifts, because it's like you have a space that has all this fluid in it, it's suddenly gone really quick within a few minutes, and the body's like, we gotta fill this space again. So fluid will rush from other spaces to go back into where you just took it out from, and you're gonna have these big electrolyte swings, these big fluid swings, and typically it might come from their intravascular space, meaning that suddenly the body redirects all of this fluid into this new area, and now you are going into like hypovolemic shock almost. So we want to make sure we avoid these huge fluid shifts, because they can be very dangerous for patients. And then, like I said, get that chest x-ray afterwards to make sure that your patient's lung has not been punctured, right? Because they're trying to stick a needle into this intramembrane space between these two membranes. If they go too far and poke through both membranes, we've just collapsed the lung. Now, if they have an infection, we're going to see this empyema when we pull out this fluid. Instead of being just like this straw yellow normal color that we're going to see from this fluid, it's going to be like pus. If that's the case, it's an infective process. They're going to need a chest tube. We probably won't be able to pull out enough of it, and the infection is going to keep producing it. So we throw a chest tube in there into the pocket of pus. It's going to be draining this nasty, milky pus out, and then we wait for it to clear up, basically, throw some aggressive antibiotics on them and clear up that infection, and boom, we're done with them. We need to address the underlying cause. If it's the infection, we do the chest tube antibiotics. If it's just fluid from an acute process, we might be able to drain it once and call it good. If we are having this effusion because of some sort of malignancy, which can be common, then we're going to do a thoracentesis to drain the fluid, because we need to get a fix on the patient, right? But if it's because of a malignancy, and say it's an inoperable tumor or a tumor that we can't get to right away, then the patient's going to need treatment for whatever that tumor is, radiation, chemotherapy, whatever that treatment may be. That's a decision for, higher up than nurses. But chances are it's going to keep reoccurring. So even if we drain it once and it's pretty much gone, it's going to build back up because it's from the tumor, and the tumor is still there. So what may end up happening, instead of just doing, we can't just keep sticking a needle in the patient over and over and over again every single day for weeks on end until their tumor is gone. So we're going to do either some sort of pleurodesis or a pleural catheter. What may end up happening is that we may have to actually chemically fuse the two, the visceral pleura and the parietal pleura together. And this is this pleurodesis, where they basically inject chemicals, usually it's actually antibiotics, I believe, into this space, and they let it kind of diffuse out, and it basically fuses the two membranes together so that your lung, instead of having these two sliding membranes, is just permanently attached to the chest wall. Painful procedure, but it does usually work for keeping this. You basically eliminate the intramembrane space there, and you can't get an effusion there if there's no space for the fluid to go. So that is a more permanent fix. Or this pleural cath can, pleural meaning in the pleural space, catheter drains away more permanently until that tumor malignancy is resolved. So those are kind of our nursing measures for these patients. I hope you have an understanding of what a pleural effusion is and what to kind of look out for on those exams, on questions that might be relevant to nursing. Hopefully I explained it in a way that you understand. If you have any questions or comments, hit me up in the comments. I'd love it if you'd like and subscribe. I will be posting some more videos soon. And if there's any topics you'd like me to cover, go ahead and put them in the comments.